So the next speaker is Dr. Manatsa Chimhamhiwa, who's just recently joined our unit as a clinical fellow in pediatric urology, who will be presenting to us the evaluation and management for a child with the ureteropelvic junction obstruction. Thanks a lot, Dr. Manatsa. Start presenting.
Thank you, Dr. Salguzana. So I'm going to be presenting on the evaluation and management of a child with the ureteropelvic junction obstruction. So as an introduction, just to make a definition of what ureteropelvic junction obstruction means, it is defined as an impaired urine flow from the renal pelvis to the proximal ureter, with subsequent dilatation of the collecting system and potential damage to the kidney. This is as per the EAU guidelines of 2021. It is noted that it is one of the most common causes of neonatal hydronephrosis, and the incidence has been noted to be 1 in 750 to about 2,000 cases, and the male to female ratio was 2:1 in the neonates. With the increase in the use of ultrasound scan, especially during antenatal follow-up and the fetal screening that often takes place, the detection of this hydronephrosis before birth has increased. Just to mention that in a study by Lebowitz and colleagues, the initial study was about, it took them about 30 years. It was from 1947 to 1977. They managed to identify 146 neonates with hydronephrosis, and these were only presenting with signs and symptoms, which were mainly an abdominal mass, or they were presenting with urosepsis. But with the increase and widespread use of antenatal ultrasound scan, it took them only 6 years to gather almost the same number of patients, about 142 patients between 1979 and 1989. And this was noted to be significant hydronephrosis on ultrasound scan. So this finding brought a change in the pattern of the neonatal hydronephrosis, and it also had implications in the investigation of management of these patients, as I shall mention as we go further. They noted that a significant proportion of these patients, they are often asymptomatic, and the studies have demonstrated spontaneous resolution, especially with follow-up ultrasound scan post-delivery. The resolution of this severe hydronephrosis, and even for high-grade hydronephrosis, grade 3 and 4, as per the Society of Fetal Urology, they noted that about 33 to 70% of these children had spontaneous resolution, but this is a wide range. They also noted that there is maintenance of renal function by use of Mag 3 renogram in about 80% of these children at 1 year follow-up. However, unfortunately, there are no accurate methods of determining which infants will lose their renal function if left untreated. So in the diagnosis and evaluation, I have to start by highlighting that there are no diagnostic tools that can identify obstruction that will lead to deterioration in renal function, or that will prevent normal renal functional development. The current standard evaluation of renal function is the diuretic renogram, but it cannot determine if a presumably normal kidney that once had an insult in utero would remain normal. Therefore, there is need to combine ultrasound scan and diuretic renogram to try and guide the management of these individual patients. There's also incorporation of voiding cystourethrogram, which is quite important in cases where there is need to exclude the other primary or other associated causes of the possible hydronephrosis, as these patients often present with the hydronephrosis. So during antenatal ultrasound scan, it's usually best to do the screening ultrasound scan at 28 weeks, where one has to determine the laterality of the hydronephrosis, the severity of the dilation of the renal collecting system, and also to assess the echogenicity of the kidneys. This echogenicity of the kidneys is important in the sense that with the increase in echogenicity, it sort of indicates the severity of the damage, especially to the renal cortical system. It shows that there is a reduced number of glomeruli, and there is also thinning of the cortex. During that ultrasound scan, there is also need to assess the ureters, to also assess the bladder, whether it's emptying or not. And it's often the sex of the child is determined, which is often guides in sort of predicting the possible causes of hydronephrosis. If you see bilateral hydronephrosis in a male infant, you would suspect posterior urethral valves, and would also want to assess the level or the adequacy of the amniotic fluid. Then postnatally, ultrasound scan should be done in patients who have been noted to have abnormalities during this fetal screening, and the fetal screening ultrasound scan should be delayed to at least 48 to 72 hours to allow for the temporal dehydration that happens in neonates. So during that same scan, one needs to assess the posterior diameter of the renal pelvis and the level of the acalicial dilatation. Then you also have to assess the same renal parenchyma thickness and the echogenicity, and you also want to assess the bladder and its residual volume if there is complete emptying or not. The significance of the voiding cystourethrogram, like I mentioned before, it sort of aid if there are any other primary or associated factors that could be causing the hydronephrosis. But of importance that it's used to detect vesicoureteral reflux, which could be present in conditions like hydronephrosis. But we have to note that it's difficult to assess for reflux in patients with hydronephrosis. Other conditions that could be excluded by voiding cystourethrogram is the posterior urethral valves. Then you also think of the ureteroceles, any diverticuli that could be present, and it can also highlight the possibility of a neurogenic blood. The gold standard is the diuretic renogram, which is important to undertake in patients who are noted to have severe hydronephrosis postnatally, or we have worsened hydronephrosis with follow-up ultrasound scan after delivery. And it is important to perform this study under standardized circumstances in terms of hydration of the patient and the presence of a transurethral catheter to keep the bladder empty, as the hold up of the hold up of the Mark III in the bladder can interfere with the interpretation of the results. Then the assessment of this diuretic renogram assesses the level of the obstruction and the level of renal function. And this can be interpreted from the differential renal uptake and the washout curves, and it also in assessing the cortical transit time during the procedure. Just to highlight the different washout curves that are noted with different pathology. For the normal one, there's prompt drainage, where with the addition of the diuretic, which is the laxis at 20 minutes, there's a sudden washout where there is a complete clearance of the renogram from the kidney. Then in cases where there is obstruction, there is plateauing of the washout curves, which signifies the obstruction. Then in some cases, you will see biphasic washout curves, which sort of herald or indicate the dynamic nature of the obstruction due to ureteropelvic junction obstruction. And this could be affected by the level of hydration of the patient, as well as the positioning of the patient. So just to mention that delayed cortical thickness, delayed cortical transit time has been associated with improved differential renal function after pyeloplasty. And this has been noted that a delay of about 3 to 8 minutes after the injection of the MAG3 has been noted that these patients often have a significant improvement if if the obstruction is corrected by pyeloplasty. Then it's important to mention that as much as it is indicated to combine ultrasound scan and diuretic renogram in following up these patients, it's not always the case that they point in one direction. Sometimes you would note that there is improvement in hydronephrosis, but with worsening of the renal function, or sometimes there is improvement or no change in hydronephrosis, but there could be improvement or worsening as well in the renal function. So just to mention about some few predictors of deterioration in ureteropelvic junction obstruction. The increase in greater than 10% in the differential renal function is noted in serial MAG3 imaging. And if there's 3 times deterioration of decrease in the renal function, it shows that these patients also have a likely chance of developing symptoms. Then the delayed cortical time, like I mentioned before. Then there's also use of other parameters like the anterior posterior pelvic diameter, the hydronephrosis index, which is calculated by subtracting the area of the renal pelvis and collecting system from the total renal area of the whole kidney and dividing by the total area of the whole kidney. Then you also have the ratio of renal parenchyma to the hydronephrosis area. So considering that these imaging modalities often come late, or the changes that are seen on imaging, they often come late, and sometimes there will be no room for salvage. So there was an attempt to try and identify biomarkers which could be used to sort of herald the onset of deterioration of the renal function before there's obvious imaging findings. So Kostick et al. And colleagues, they sampled the urine and blood, and they were trying to identify markers of which they noted markers like neutrophil gelatinous associated protein, then the kidney injury molecule, and the rest of these other molecules. And they noted that these molecules, proteins, they decrease in their levels after surgery for patients who had the ureteropelvic junction. But of note that they are not in routine clinical practice, and they have not yet been recommended for the routine use. So the treatment options that are available is room for observation. In some cases, there is room for giving continuous prophylactic antibiotics, and the definitive is surgery to correct the obstruction. The absolute indications for surgery, mainly they are patients who are symptomatic, that is those patients with recurrent urinary tract infections, patients who have developed kidney stones or who have developed hematuria, or patients who have got a mass effect because of the severely dilated kidneys. Then patients with a clinically obstructed solitary kidney, this often need a surgery immediately. And if there's evidence of reduced overall renal function, there's need to intervene. The indications for surgery during follow-up, if there's decrease in diuretic differential renal function of greater than 10% on subsequent studies, or if there's a consecutive drop in differential renal function on follow-up renogram, then if there's evidence of obstruction, as in the plateauing of the diuretic curves and the held up of contrast during the renogram, is also an indication for surgery. Then with the ultrasound scan, increase in anterior posterior renal diameter, and patients who sort of have their hydronephrosis worsening from grade 1 to 2, from grade 1 or 2 to grade 3 or 4 hydronephrosis as defined by the Society of Fetal Urology. So I've just put up an algorithm to try and put an approach to the management of hydronephrosis postnatally. Just indicate that for those patients with severe hydronephrosis, they often progress to proceed to do a Mark 3 study and try and determine the differential renal function. And then for those who have got greater than 45%, they could be followed up with an ultrasound scan every 3 months for 12 months. If they remain stable, it's optional to continue monitoring them monthly for up to 18 months. Then for those patients who have got differential renal function less than 35%, it's an indication for surgery. But in most studies, the quoted figure is less than 40%. Then for patients who have got mild to moderate hydronephrosis postnatally, there's need to follow them up with the ultrasound scan every 6 months. And if there's resolution or there's improvement, if there's a resolution, there's no need to continue following them up. But if there's improvement, this needs to be monitored. If there's worsening of hydronephrosis, there's need to proceed and do the diuretic renogram. The surgical treatment options of ureteropelvic junction. The Anderson-Hines dismembered pyeloplasty is considered the gold standard approach. But today there's use of laparoscopy and robotic assisted laparoscopic pyeloplasty. And despite them having technical difficulties, considering that it's difficult to achieve adequate pneumoperitoneum in these young children, their success rates have been noted to be quite high in good hands, ranging from about 92 to 99%. So in conclusion, detection of hydronephrosis secondary to ureteropelvic junction by ultrasound scan has increased the number of asymptomatic cases. And this has posed a challenge as these patients, as one cannot determine who would need a continuous follow-up and who would have their renal function worsening or resolving spontaneously. It is important to mention that the majority of these patients have resolution of their hydronephrosis, except a few who would need this continuous follow-up, as I had highlighted. And the early signs of worsening renal function should be identified and managed early to preserve the renal functional potential. Thank you.
Thanks a lot, Dr. Manatsa, for a great talk. Just a quick question from my side. Do you guys, back in the institution, do you use a lot of renograms to decide and when to intervene, or mostly in ultrasound? What has been your experience back in your institutions in terms of the indications for surgery and maybe how you follow up these patients post?
Yeah, from my few months of experience with the Red Cross, they combine both diuretic renogram and ultrasound scan. But the regularity of doing a Mark 3 study is less frequent as compared to that of ultrasound scan. And the ultrasound scan the findings on ultrasound scan are often used to indicate whether one needs to go for a renogram or not.
All right, thanks a lot. There's a question from a participant who they're asking, how would you decide if there's bilateral PUJs? How would you decide which side to start with?
Hello, can you come again?
They want to know if you've got bilateral ureteropelvic junction obstruction, how do you decide which side to start with when you're doing your intervention, a surgical intervention?
When you have a patient with the bilateral ureteropelvic junction, the best option to manage is to start correcting the side with the better renal function to preserve the kidney that has got the highest potential of recovery, as compared to repairing the kidney that is at significant damage, as this potential for recovery could have already been lost. And you waste time before you repair the side which has got the higher potential for recovery.
Thanks. Sorry, there's a question, a comment from Prof. Lazarus.
Thanks, Samkele. Perhaps I can just try and answer that question. I think that we at Red Cross Hospital would employ a differential GFR. In other words, the books tell you up to 40% of PUJ cases can be bilateral, but I think that's an overestimation. I haven't thought it's as high as that. But certainly you now don't have a normal kidney to compare the abnormal kidney with. And so your question is a good one. How on earth are you going to determine that? And so the nuclear medicine people are able to do individualized GFRs for both kidneys. And then that allows, in a serial manner with ongoing follow-up with ultrasounds and further renograms, to determine if there's a fall in one of those kidneys. And that can be useful in your decision-making.
Thanks, Prof. So Dr. Lamini raised her hand earlier. Okay. Okay, no, I think in the absence of further questions or comments, thank you so much to our speakers today, to the clear vocal, Dr. Manatsa Chimhamhiwa. It's really been a great morning and interesting discussions. We'll see everyone in the next week. Thank you.